Okay, welcome back. Welcome back to me, but welcome everybody. My name is Shayna Jacques. I am the outreach manager for PSS Circle of Care, and I thank you for participate to this webinar today. The title of this webinar is Genetic Testing and the Era of Precision Medicine. Our presenter name is Professor Jill Goldman. She is a professor of genetic counseling and neurology at Columbia University Medical Center. She will review how neurologists identify inheritance pattern in family history. Recognize the gene associated with AD, meaning and distinguish the physiology issues involved with genetic testing for AD. Sorry. Jill Goldman, he's a genetic counselor, like I mentioned before, at the top institute at Columbia University Medical Center, where she is a partner in the Center of Excellence for Alzheimer's disease. She worked as a genetic counselor since 2000. Before that, she was a health education specialist and science teacher. And some of you might know about PSS, but I'm just gonna quickly do a quick overview about our agency. PSS founded in 1962. Is a multi-service agency who has for mission to strengthen the capacity of older New Yorker, their family and community to thrive. With our PSS Live University, we offer a lot of educational programs, either online or in person. We are at our senior center. All these locations are designed to help older adults to stay healthy, engaged, and connected. We also have a PSS Circle of Care program that I am currently working under this department. We provide free personalized support for those caring for someone who is frail, chronically ill, or has memory loss issues. We do also have a family where a grandparent or a family member of the parent is raising a grandchild. Our grandparent family is the first in the U.S. residence purposely built for grandparent raising grandchildren. The next and other program we do have is the coming of age. It inspires people 50 plus to live with passion and purpose. We also have our volunteer program who serve an important role in delivering our services. What we're gonna do, if you have any questions and comment, please add it to the Q&A box. You can also put it on the chat box, but we'll wait at the end of the presentation to add any questions that you might have, okay? This webinar will be recorded. If you are missing a part of it or want to review it again, you can visit it at pssusa.org/resources. You're gonna see all the past webinar we had. And then for more information about our services, you can visit us at psscaregiver.org. For coming of age is coming of age, nyc.org. For all of the event, you probably see it on our website. It's pssusa.org/event. I'll thank you all.
Hi, everybody. Sorry about the technical problems last week. Hopefully we will do better this week. Okay, so as Sheena said, I am a genetic counselor at Columbia Medical Center and see patients with adult onset neurodegenerative disease, such as Alzheimer's disease. So what we're going to do today is look at different types of family histories to try to figure out how genetic the Alzheimer's disease is in the family. We're going to talk about when you actually consider genetic testing and what you have to think about. We'll go over the basic genetics of Alzheimer's disease and the process of counseling and testing. and the psychosocial issues involved in genetic testing for dementia, and then do a look at direct-to-consumer testing like 23andMe, and then just to think about briefly what you would do for your patients if they test positive. Okay, so for a minute, I want you to imagine that you are the 25-year-old woman that the arrow is pointing to. So those of you who aren't familiar with genetic pedigrees, circles are women, squares are men, and the darker color are people with Alzheimer's disease, their current age or their age of death, and then when they develop symptoms. So this young lady has a definite phenotype of Alzheimer's disease that starts about the age of 50 to 55. That would not be a requirement of everybody who develops the disease. It's just who has developed at this point. She would be at 50% risk if her father is positive. We could test her directly, but there are some problems with doing that, because if we get a negative result, we don't know if we've tested the right genes. If we get a positive result, we have also disclosed her father's status, and he may not want to know. So genetic testing is complicated. Before someone has genetic testing, they have to think about a bunch of things, including, is there anything that you can do for this condition? In the case of Alzheimer's disease, the answer is no. You have to think about how knowing the results would either help or harm your life. You have to think about who you're going to share these results with. That if she shared it with her father, he would know that he's going to get it. And that could have a bad effect on other family members and on relationships. So we all know that the numbers are very scary. There are 5.8 million people in the U.S. right now with Alzheimer's disease. Most of those have onset of 65 or older, but there are about 200,000 people in the U.S. who develop the disease under 65. And it is these people who are more likely to have a genetic cause of their disease, but not always. Only about 1% of all of Alzheimer's is what we call dominantly inherited early onset Alzheimer's disease, where you have a gene and you will definitely get the disease. Okay. Now, one of the really important things to remember when we're talking about genetic risk of Alzheimer's disease, and we see a family history, is, are we sure that everybody in the family had Alzheimer's disease? Dementia is the umbrella term under which many different types of diseases are found. So Alzheimer's disease is definitely the most common dementia, but certainly not the only dementia, with the second most common types being vascular dementia and Lewy body disease. And then frontotemporal dementia and others are a little bit less frequent. So you have a family history, and here my grandma had Alzheimer's disease. It's really important to explore that and explore what the symptoms were like to try to confirm that this is actually Alzheimer's disease. Okay, so again, when we look at Alzheimer's disease family histories, we see three different types. This one over here is the most common. It would be sporadic Alzheimer's disease, one person in the family. Even if this person is relatively young, that would not be typical of the strongly genetic types of Alzheimer's. We switch over here to the autosomal dominant family history, and what you're seeing is that every affected person is a first-degree relative of somebody else with the disease. And you're also seeing that these three people died in their 60s of Alzheimer's disease, and this person is quite young for getting Alzheimer's disease. So age of onset is young. And that's a definitely genetic form of Alzheimer's disease. And then we see what we call familial Alzheimer's disease, where there is more disease in the family than you would typically expect. But here you're seeing that this person seemed to have died before contracting the disease. We don't know if that person would have gotten the disease. So it sort of looks like it skipped a generation. The other thing here is that these people had late onset disease, where this one is early. So you get this mix of late and early disease. And that is not an autosomal dominant type of family history. Okay, so what do we know about genetic risk of Alzheimer's? If you have a first-degree relative, so a sibling or a parent with the disease, you are definitely at a greater risk, regardless of genetic testing. Okay, it's about a 3-time greater risk, and that's so generally true if your parent has any disease, whether it be heart disease or diabetes or cancer, you're at a greater risk. Okay, this little slice of the pie here is our autosomal dominant cases that I was describing before. Probably greater number than I have here in yellow is familial, or at least has some genetic risk factors without being autosomal dominant. But we do not at this point know all of those risk factors. Okay, so when you have a heavy-duty family history of a disease like Alzheimer's disease, it's really scary. And most people have experienced, very unfortunate circumstances because their loved one has gotten the disease early in life. And you or your patient might have been a child or a teenager when their parent got sick. So in many families, there's sort of an unsaid rule not to talk about it, but it's really, really important to talk with professionals who understand what it's like to live in a family with hereditary disease. There also can be lots of misconceptions based on the experience of that person, which is a small experience. They've only experienced their family, so they may not really understand everything to know about hereditary Alzheimer's disease. So right now, I'm going to go over sort of genetics 101 the way I would with patients. And I'm going to describe autosomal dominant. So your patient has a father who has early onset Alzheimer's disease. There's more family history than that. Let's say also had the disease. So we are assuming that this person, even if he hasn't been tested, has a genetic mutation or variant in one of the Alzheimer's genes. We have 2 copies of every cell, of every gene in every cell in our body. One from mom and one from dad that comes into the fertilized cell and then duplicates every time that cell duplicates. So this person has one mutation or pathogenic variant in the Alzheimer's disease, and one normal gene. His wife here has two normal genes. So throw the quarter into the air and it's going to land heads or tails. Either the gene with the mutation will be passed on or the normal gene will be passed on. This is a 50% risk for every child. So here you're seeing they had 4 childs and the average would be, 50-50, two with, 2 without, but it doesn't have to be like that. All 4 children could get the mutation. All 4 children could be spared, or it could be 2 and 2 or 3 and 1. So when I talk about a mutation, I'm talking about a change in the DNA. So our genes are on chromosomes. We inherit 23 pairs of chromosomes, 1 pair from each parent. Each chromosome has hundreds of genes on it. And what you're seeing here is they've unraveled the chromosome to show you that it's made of DNA. And DNA, in turn, is made up of these molecules, which we abbreviate G, A, C, and T. And they form a sequence along the DNA that gives information for making proteins. Okay, so you're seeing that sequence here, and you're seeing the proteins that are coded by that sequence here. Now, if the normal sequence reads cat, 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 cat is a 3-letter code, and we change one of those, so here, this A has been changed to a C. This 3 letters here, CCT, has a different meaning than CAT, and it codes for a different amino acid in the protein, so that the protein that is formed is not going to be able to function the way it normally functions. And that's what causes disease. So there are different kinds of mutations. So again, the normal one, okay, we have here a missense mutation. Okay, 1 letter has been changed. Okay, instead of saying, as the man saw the dog, it's now, as the man saw the dot. We can take out some of the letters. So here, the DOT was taken out, and now it says, saw the hit, that's called a deletion. We've added some here, saw the fat dog, that's an insertion. Or we have actually shifted this whole thing by taking out a single letter. If we take out that FATD, then we have something that doesn't make sense at all, okay? And the protein would actually stop here and never be formed. Okay, so anytime I talk about mutation, I am talking about one of those types of mutation. So when we look at can cause Alzheimer's disease, and here again, I'm talking about the autosomal dominant type. If you have the gene, you are definitely getting the disease. And there are 3 genes: amyloid precursor protein gene, presenilin 1, and presenilin 2. Presenilin 1 is the most common. And then we have a number of genes that we call susceptibility factors or risk factors. And the one that's most associated with risk is this ApoE type 4. Okay, so just a little case example here shows you some of the difficulties with testing for Alzheimer's disease. A 60-year-old woman with a 6-year history of memory loss presents to clinic with her adult daughter and identical twin sister. So her onset is 54. That is what we would classify as early onset Alzheimer's disease. So basically they're coming in because this daughter wants to know, because she wants information for her reproduction, her options for reproduction. The twin sister, however, doesn't want to know, and the patient's very upset by this decision. So there are lots of different issues here. If she has a mutation in one of these genes, and her twin sister also inherits the same DNA, the twin sister also has the mutation and will develop Alzheimer's disease, and probably very soon. Okay. The other issue here is, does the patient have the capacity to really give informed consent? Will she be coerced by her daughter or by her sister and make a choice to please one of them? So this gets very complicated when you're talking about people who even have early dementia and still technically have capacity, but might not be thinking very clearly. In this case, the sister said, "Oh, go ahead and do it because I'm going to get it anyway, if I have this gene." Okay, so if we tested her or another one of our patients, at this point in time, we would send off a whole panel of genes. I am pointing here to the 3 Alzheimer's genes, but there's a slew more that are genes for other dementias as well as ALS, Lou Gehrig's disease, and we'll talk about why that's so. The cost of genetic testing has gone way down. For this particular lab, it's called Invitae, but there are many other labs that also do this. There is a difference between the cost if you go through insurance versus out-of-pocket, the out-of-pocket cost can be very low no matter how many genes you are actually testing. Okay, now we like to know the mutation in an affected family member. It gives us a much better feeling for testing predictively in someone who does not yet have the disease. So we can get different results. We can get a positive result where there is a definite mutation that has been discovered, and we can predict that that person will either have Alzheimer's disease or will develop Alzheimer's disease. We can get a negative result where no variants are found. And if we're testing someone with the disease, we can say, well, your disease isn't due to genetic causes. If we're testing somebody predictively and we don't have a known mutation in the family, all we can say is, you don't have one of the genes that we've tested for, but we don't know the gene in your family to start with, so maybe we didn't test for the right genes. And unfortunately, there is a third result, which can be very frustrating. And this is particularly true when we're using a gene panel and we're testing a lot of genes. And we can get what's called a variant of unknown significance, which means that they have discovered a gene variant, but they're not sure what it means. It hasn't been in the literature before, or it hasn't been associated with the disease it's being tested for. And if we get one of those variants, and sometimes we get more than one variant, there is nothing that we can say to the family. We can't say, you definitely have a genetic form, or you definitely don't have a genetic form, and we can't test somebody predictively using that variant because we don't know what it means. Labs will reclassify these variants over time as more and more data comes in. This is what the result looks like, where it says at the DNA level, so at the gene level, what should have been a G is now a C. So that is a missense mutation that has changed. And at the protein level, at this particular spot, this amino acid has shifted to this amino acid. So that would be a definite positive result. Okay. Just to talk to you about what's happening when someone is thinking about predictive testing, we know based on the Diane study, which is an inherited Alzheimer's network study, that Alzheimer's disease starts way before you actually see clinical symptoms and get a clinical diagnosis of mild cognitive impairment that then goes on to become full dementia. You can see that there are changes in MRI that are subtle but are detectable by researchers, changes in PET scans, and changes in the amount of amyloid, one of the proteins that is responsible for Alzheimer's disease, 10 to 15 or even 20 years before the onset of clinical symptoms. This is important because when we have drug studies, we want to start giving those drugs down here before there's too much damage to the brain. And the best candidates for these studies are people who carry the mutations but don't yet have the disease. Okay, so when somebody says, I want to have predictive testing, we don't just test them. We take this very seriously. We think that people should really, really understand all the implications of learning this information and think about it very carefully. So a protocol has been studied for a very long time in a different disease, Huntington's disease, which is 100% genetic. And guidelines for testing have been set up using this protocol. So there's a telephone screen where you take a family history, you learn about the person's motivation, and you discuss the GINA law. GINA is the Genetic Information Non-Discrimination Act that protects people from discrimination based on either family history or genetic results, from any discrimination in the workplace or in health insurance. What it doesn't cover is long-term care, life insurance, and disability insurance. So we inform people interested in testing and tell them that the safest thing to do, if they can and want to, is to get other insurance that they might want in the future now before they get their test results. Okay. They then come in, preferably with somebody else as a support person, to see the genetic counselor for education and for really guidance about what this is going to mean to them. And then they should have a psychiatric assessment to make sure that they can deal with the information. This is especially important if people have had a history of anxiety or depression. They then sign an informed consent, blood is drawn, and they return in person for results, hopefully with their support person. But every site varies a little, and the cost of doing a protocol will depend on the protocol at that site. Okay, so why would somebody want to know that they're going to get a fatal disease? The answer really is three different things, mainly three different things for now. For reproductive choices, which would include not having children, adoption, sperm egg donation, pre-implantation genetic diagnosis, which I'm going to talk about in a minute, or just going ahead and saying, by the time my children reach the age where they would get this disease, it's going to be a cure, and I'm just going to do it the old-fashioned way. So that's motivation number one. Motivation number two is life planning. Thinking about, well, if I'm going to get this disease, I want to retire early, I want to travel, or I'm thinking about getting a second college degree, and I don't want to spend all that money if I'm not going to be able to practice medicine for a long time. The third reason is some people really can't deal with the uncertainty of not knowing. They say, it would be better for me to know my status than not know my status. And then the last would be if they could be a candidate in a trial if they know that they carry a mutation. Okay, so I mentioned pre-implantation genetic testing. So if somebody says, okay, I want to learn my status so I don't transmit this gene to my child, they can go through in vitro fertilization, produce embryos, and then at about the 5-day stage, the embryo can have what they call a biopsy, where they take off a cell or two and test those cells for the specific mutation in the parent. And then they only transfer embryos that do not carry that gene. So it is a wonderful option. It is extraordinarily expensive. Some people have insurance that will cover IVF with or without PGT, others not so much. And the expense is different in each state, in each city. In New York, it's about $25,000 each round, and IVF doesn't always work, so there might have to be extra rounds. Okay, so if you're thinking about predictive testing, what do you have to think about? What would your reaction be? Over the short term, over the long term? What if it's negative and there are other family members who have tested positive? Would you feel guilty? Can you adapt to your result so that this is allowing you to take more, not less, control over your life? We certainly don't want people falling apart every time they forget a word or their keys or get lost. Who are they going to share the information with, and do these people want to know? And we suggest that perhaps they have a discussion with their relatives prior to getting test results. How's it going to affect your partner? And that's one of the reasons for having that person at the genetic counseling session, so that that conversation can come up. And how's it going to affect other family members? Do you have enough support? Should you have a therapist in place? Okay. Where is this information going to go? Is it going to go in your electronic medical records, where insurance theoretically could access the information? So it's important for people to find out if their provider will keep this information out of electronic medical records or not. Okay. How are you going to deal with a VUS if you get a variant of unknown significance? Okay, so another case history here. A 43-year-old woman called for an appointment for genetic counseling after she was referred by her doctor following predictive testing. Her mother had recently died after a 12-year course, so mom got the disease relatively early. She had other family members with the disease, although it was later in life. This woman was told by her provider's nurse practitioner that she carried a gene for early onset Alzheimer's disease, and she was terrified. So when I got this call, I asked her to provide the actual test results. I didn't want to take her at her word. You know, someone who is very scared is telling me secondhand information. I wanted to see the real thing. So this is the same panel that I showed you before. And the result actually was a variant of unknown significance in this TBK1 gene. This is not an Alzheimer's gene. This is actually a gene that can cause frontotemporal dementia or ALS. And it's a variant of unknown significance. So the provider really didn't have the right to say you have a gene for Alzheimer's disease on multiple accounts. What's also important is this woman had no real proof that her relatives had AD. They could have had a different dementia. They hadn't tested other family members ahead of time. So it was important to look back at the medical records from her mom, which unfortunately she couldn't access. Okay, so let me just talk about FTD as a second dementia that could be an alternative to Alzheimer's in a family history. This generally presents very differently. It generally presents behavioral or personality change or language impairment where memory is relatively preserved. So questions about what were the early symptoms? Was the person forgetful? Did they repeat questions? Did they get lost? Versus were there changes in behavior or language? Okay, and there are totally different genes. So testing only Alzheimer's genes would not be testing for frontotemporal dementia if that happened to be the dementia in the family. Okay, so going back to when somebody is thinking about predictive testing, as I said, we want them to be as sure as they can be, and not resent the fact that they did this testing after the fact, because you can't give the information back. Okay, now just a quick look at direct-to-consumer testing. This is a young man who went through 23andMe for different types of testing and got a shocking result. So his name was Matt Fender. You can see it was in the New York Times, so I can reveal that information. He was actually an IT, very savvy guy. And he decided to do 23andMe because his sister had died at a young age, and he wanted to see if anything he could discover that could explain that risk. Instead, he found out that he carried the risk factor gene ApoE4, and he had 2 copies of it, which put him at significant risk for Alzheimer's disease, yet still not that 50% risk of autosomal dominant. And he tried to talk to his doctor about this, but many doctors really don't understand genetics, particularly of Alzheimer's disease, so the doctor was not helpful. So I don't know if anybody on the webinar has done 23andMe. What you do is you sign up, you pay your money, and you get a package that looks like this, that has this test tube. And you need to spit in this test tube to get enough saliva that they can test, and it's a significant amount of saliva. You send it off, and you get different types of results. You can just do ancestry, or you can do ancestry and wellness. And in your wellness reports, you get information that's not going to be terribly helpful to you, like do you turn red when you drink alcohol? You get other just trait information, such as you happen to do have a risk for having a dimple in your cheek. And you get information about carrier status for autosomal recessive diseases. These are diseases such as Tay-Sachs disease or cystic fibrosis, where you need 2 copies, one from mom and one from dad, in order to get the disease. So to find out that you are a carrier is important information for production. However, 23andMe only tests for about 40 of these, and if you're doing it for reproductive risk, then bigger panels. And then there are the autosomal dominant diseases that you can find out. You don't automatically find out. You have to say yes to those. And that includes Alzheimer's disease, Parkinson's disease, and breast cancer. But the important thing here is you really have to understand what you're testing for. Here for the Alzheimer's risk, you are only testing for ApoE, which, as I said, is a risk factor, not a definitive gene. And if you don't have any copies of the ApoE4 gene, that really doesn't reduce your risk if you have a family history anyway. And that's really important. And it's true for the Parkinson's testing and the breast cancer test as well. Okay, so back to our case history. He did one more thing when he did his 23andMe, and that was to ask for his raw data, which we don't do automatically. You have to ask for that. And 23andMe and the other companies do not guarantee the results of this raw data because they don't have approval from the FDA to do that guarantee. So Matt took his raw data and sent it to a website called, this is spelled wrong, it's called Promethease. And he discovered he had one of the autosomal dominant genes that tells him that he would definitely get early onset Alzheimer's disease. And that's when he contacted me. I asked him if he wanted to have the clinical testing, approved testing. This is the FDA approved labs. And he said, well, he had already sent a second sample to Ancestry.com and wanted to wait until that came back. So his results from Ancestry came back and said he did not have this gene mutation. He eventually got tested clinically, and he was found not to have the mutation. So the bottom line here is that the direct-to-consumer tests can vary a lot. There are no guarantees that their information is correct, and it's sort of buyer beware. And definitely get genetic counseling before doing any kind of genetic testing, even the direct consumer. So a little bit more about this ApoE gene. If I were to test everybody in the general population, I'd get a distribution that looks sort of like this. Most of us have the neutral ApoE3 gene, but it's about 40% of the population walking around with at least one ApoE4. And these people are at greater risk of Alzheimer's disease, but they may never develop the disease. ApoE2, which is the rarest form, is protective against Alzheimer's disease. If I go into my clinic, I get a different distribution. So you're seeing that people with Alzheimer's disease already diagnosed are more likely to have this ApoE4. but a large percentage of people with Alzheimer's don't have ApoE4. So it's neither necessary nor sufficient for developing the disease. And the risk sort of looks like this. If you have no copies, you're still at risk. By the age of 80, we all are. If you have one copy, that risk increases 2 to 3 times. If you have 2 copies, it goes up much further. But actually, the latest papers say risk is only up about 40%. And early papers were saying that it was like 80% risk. So the more we know, the more we know. This again is the distribution of all of these different genotypes in men and women, and you can see that women are at greater risk if they carry an ApoE4 allele. We unfortunately are at greater risk even if we don't. And here you can see that if you are Caucasian, the risk is greater than if you are African American or Hispanic. There are many other risk genes that can generally confer less risk than ApoE, depending on your ethnicity. This ABCA7 gene confers about the same amount as ApoE in the African American population. So this is sort of the sum of everything we've talked about. Are 3 rare genes that confer the highest risk of Alzheimer's disease. Probably the next highest risk would be if you carry 2 ApoE4. Then there's a bunch of lower risk genes that are relatively rare. If you carry 1 ApoE4, you're out here. Still lower risk, but you're at higher risk than if you have none. And then there's this slew of risk factors that are very common, but carry a slightly increased risk. We are now beginning to talk about taking all of these genes and combining them into what's called a polygenic risk score, which might be a little bit more effective at predicting risk for risk factor genes. But you also have to take into account environmental factors such as education, head trauma, and then cardiovascular risk. And I should say that having an ApoE4 allele also increases your risk of cardiovascular disease. And that is something that people can do something about by having a heart-friendly diet and exercise. So what you do for your patients, you refer them to support groups, you get psychiatric referral as necessary, and you help them to live for today while they're taking care of the future. What you don't do is send them out to buy all different kinds of supplements that have been shown to have no positive effect at all. If they carry an autosomal dominant gene, they can be referred to the DIAN study. There are 2 arms of this. One is an observational study, and one is actually drug studies. And then there's the support groups, or support associations, including Circle of Care, which should be up here, but also the Alzheimer's Association for Frontotemporal Dementia, the Creutzfeldt-Jakob Association for people with prion disease. So that's it, and I'm wondering if there are any questions.
Thank you, Jill. Let me check. If anybody has any question, you can add it to the Q&A box. That was a very thorough and really good presentation, a lot of information. Yes, if anybody has any question, you can just add it on the Q&A box. Professor, I don't see your information. You didn't add a slide or have your information.
Excuse me?
Do you have a slide where it has your information, your email address?
Oh, I just closed everything.
Okay.
So my email address is jg2063@cumc.columbia.edu.
Yes, if anybody wants to reach out to you, they can reach out to that email, correct?
Yep.
So if you, for now, you don't, anybody don't, if you guys don't have any question and then you come up with some after the presentation for today, you can definitely reach out to Professor Jill Goldman. Again, Professor, thank you. And we did it today. Everything went well.
Yay.
So,
Thank you very much.
I thank you again. And thank you, everyone. And have a great day.
All right. Bye-bye.
Bye-bye now.